Unless someone wants to wait another 2 minutes, but otherwise we can start a bit ahead of time.
Raise your hand if you want us to wait.
Good morning. Welcome, everyone. Thanks for being in this very small box with us. It's a pleasure to welcome you. My name is Nicolas Gaspard. I'm head of neurology at the Brussels University Hospital, a few minutes from this place. And this is Professor Shawniqua Roberson. She's assistant professor of neurology at Vanderbilt University, where she also heads the ICUG monitoring program. And this morning we have for you a complex case of status epilepticus. The idea is to go over the case, and as we go along with each step of management, we're going to interact with you, ask you questions, what you would do, what you call things, and so it's supposed to be a very interactive session. So please don't be shy, ask questions, answer the questions, and we'll be happy to interact with you as well.
And just one request, when you have comments, please just let us know. We'll give you the microphone because I can tell already that I cannot hear, so other people may not be able to hear you.
Yeah, good point. It's quite loud out there. All right, so let's start. So this is a case we had a few years ago, a 23-year-old male, no significant past medical history, he has a mild febrile illness, diarrhea, vomiting a few days before he was admitted to the hospital. He started having focal motor seizures with the right facial clonic movement, like things like that, with impaired awareness, a few of them, and then the seizures became more and more frequent. They evolved to generalized convulsions, and he was admitted after this episode of convulsion. You see him in the emergency room. He's post-ictal, somnolent, drowsy, does not follow commands. And as you're examining the patient, he has another seizure, another convulsion right in front of you. So this is status epilepticus, right? But what is the definition of status epilepticus, and what is the recommended first-line treatment in status epilepticus? Anyone wants to give it a go? What's the definition of status epilepticus? Yeah, I see someone trying there.
First, recommend benzodiazepine.
Okay.
And no status epilepticus, you will stay time, but this is a first patient situation. Need a time, and the clinical pictures I've developed in this time.
Right, so first-line treatment, benzodiazepine, I like that. But how do you define status epilepticus?
It's a state of recurrent seizures with impaired mental status who doesn't come back to the normal between seizures.
Excellent, very good. That's what I would say as well. Exactly that, a state of continuous seizure or a state of recurrent seizures in between without return to baseline in between. We can actually define it according to, as you mentioned, different clinical conditions, so tonic-clonic status epilepticus, focal status epilepticus with impaired consciousness, or absence status epilepticus. And we define it according to 2 time points in particular. Okay, there's an operational dimension time T1 that determines the time point at which the seizure is most likely to continue without some sort of medical intervention. Okay, for the tonic-clonic status epilepticus, there we go. For the tonic-clonic status epilepticus, that's been defined operationally as 5 minutes into the tonic-clonic seizure. For focal status epilepticus, about 10 minutes, and then with absence, we're not quite sure, but 10 to 15 minutes of prolonged seizure activity. Then there's the time 2 operational dimension, the operational dimension time 2, after which continuous seizure activity is likely to induce ongoing long-term consequences in terms of neuronal death and cellular changes, okay? This has been defined as 30 minutes for the convulsive seizures and greater than 60 minutes for the focal with impaired awareness. It's not quite known as of now as far as the absence status epilepticus, if and how long it takes in order to identify in order to sort of incur long-term damages. Clear? Questions? All right. So first line, as we mentioned, absolutely, benzodiazepines. And these were well established in three studies in particular, the VA cooperative study, the out-of-hospital study, and the Rampart study that looked at out-of-hospital status epilepticus efforts and compared medications as far as these are concerned. The well, I won't go through all the details of the studies, but with the coming down to basically the output, if you will, intramuscular midazolam is useful if there's no IV access, or intravenous lorazepam is a good option. You can dose these as you see here, and you can actually repeat them. And then if these are also been identified as essentially equivalent choices, intravenous diazepam, intravenous clonazepam, phenobarbital, or rectal diazepam, or now becoming more readily available is intranasal midazolam, which is available for your patients as outpatients if necessary. Okay, so we will also talk about the overall guidelines that are available. The most recent guidelines are from the 2016 American Epilepsy Society guidelines that proposed a full algorithms, and within the first 0 to 5 minutes is where you would be stabilizing the patient. You would be checking for all of your ABCs and Ds and Es and monitoring of your vital signs and getting your finger sticks. You would also be sending labs, electrolytes, etc. And importantly, you'd be sending anti-seizure medication levels if that is appropriate in your folks who, if you know already that they have a history of epilepsy, prior seizures. You would also consider brain imaging. We'll talk about that a little bit. After the 5 to 20 minute phase, we'll go into this case further. But just to let you know that these things exist. So this person receives IV lorazepam. The convulsion cease initially, but they continue to have frequent just one arm jerking, okay? Focal motor seizures, arm, and we mentioned the face switching before. And they're also continuing to be impaired in terms of their consciousness. They're not arousing, they're not interacting with you. These are happening every 10 minutes. So what term describes this presentation, and which anti-seizure medication has the strongest evidence in this context? Thoughts from the crowd?
Don't be shy.
Oops, I hear something. Thank you.
Partial status epilepticus.
Yeah, so that's how you describe it in terms of semiology. We would say focal status epilepticus nowadays, not partial anymore. But how do you describe the situation in terms of response to treatment and where you are in this algorithm of giving medications to try it to stop?
Refractory status epilepticus.
Yeah, getting there, not quite yet.
Thank you for these responses. Was there another?
So we're kind of in between. The patient didn't respond to the first line, but he hasn't got the second line yet. Right? Refractoriness is when the patient is refractory to 2 lines of treatment. So the patient just failed the benzo. So this is established status epilepticus. Do you know what you have to do with established status epilepticus? There is a well-known study that came out a couple years ago, well, a bit more than that now, that tells you exactly what we need to do. Established status epilepticus treatment trial, the ESET trial, came out in New England in 2019 and compared IV levetiracetam, IV fosphonate, and IV valproate. This is a very simple study to summarize. Same efficacy, same safety. So all 3 are kind of equivalent in this setting. Just mention the dose. These are very high doses. Easy to remember, 20, 40, 60. 20 for phosphonatein, you all know that. That's what we've been using for decades. 40 for valproic acid, that's much higher than what we used to do in the past. So 40 mg per kg of valproic acid and 60 mg per kg of levetiracetam. Don't ask me why they picked these doses. There is really no rational, or rational is very simple, but that's what they picked, and that's what we should use nowadays. So 20, 40, 60, same efficacy, same safety. So basically, you got to pick the drug based on their side effect profile and contraindications, right? Phenytoin, bad idea in an old patient with a failing heart. Levetiracetam is a patient with a psych history, maybe not good. Valproic acid contraindicated in kids under 2-year-old because of the risk of metabolic diseases. But other than that, they are equivalent.
Can I add one comment
Sure.
about? So, as you're trying to act quickly and get your patients their medications as quickly as possible, one practical limitation or one practical consideration is that if you are operating in your hospital, your pharmacy may have to specially prepare these medications, or if you are requesting exact dosing for the weight. So, for example, at our hospitals, several of the hospitals that I've been at, Keppra comes in 1 kilogram bags, right? And so often what I will do is simply estimate 60 mg per kg, but then round to the appropriate, give me 4. Just so that I can, because that way I don't have to wait half an hour for them to prepare the bag, mix it, bring it down, etc. They will just grab it and from the bin and pull it in. So this is just a practical consideration.
Yeah, that's a good point. And in all these 3 drugs, I feel that levetiracetam is the most benign. You're never going to kill anyone by giving 60, 70, 80 milligram per kilogram of levetiracetam. With phenytoin, it's slightly different, and valproic acid is somewhere in between. So, right, I would go with levetiracetam because of the safety profile. And yeah, I round up as well. And I mean, if it's 5 grams instead of 4.5, doesn't really matter. But at least 60 milligram per kilogram. All right, so we did think by the book. The patient got loaded with valproic acid, 2.4 gram IV, and then was put in continuous IV drip. There is no clinical sign of seizure anymore. Well done. The patient is not shaking anymore, no convulsions, no focal motor activity, but he doesn't wake up. Remains stuporous. GCS of E2, V2, M4, 8 out of 15. What's happening? And what do you think we should do? The patient is just delirious. It's post-ictal delirium. Just, leave him rest. It's going to be fine. The patient's at risk of stroke or in the post-ictal phase, so we need a head CT, a stat CT. The patient's at risk of a new onset epilepsy and needs a routine EEG. Or the patient's at risk of non-convulsive status epilepticus and he needs head CT and continuous EEG. So who goes with 1? Hands up. Who votes for 1? No one. Good. Who goes for 2? No hands raised. Excellent. 3. No. Oh, a few hands. Okay, well, EEG is a good idea. Who goes with 4?
Wow.
Excellent. We should have come this morning. They know everything.
They know
right?
everything.
They know
Someone else
everything.
here could be up.
All right, indeed. So
Yes, so indeed, we are certainly concerned for ongoing subclinical or electrographic seizures. And I agree with number 3 in that the person needed a routine, at least a routine EEG. But I would say a step further in that we also need a head CT because we're concerned about this non-convulsive status epilepticus. So we have prior trials with the De Lorenzo trial as well as Jaitley and Alvarez more recently in 2015 that actually were able to demonstrate that post-convulsive or non-convulsive status epilepticus, which we might call subtle status epilepticus, maybe they're maybe just having a few brief moments, etc. Most commonly were identified. Non-convulsive status epilepticus was identified in up to 51% of cases, and so you should definitely be performing these EEGs to identify this in your patients because unless you treat actively, they're going to continue to have seizures without intervention. So here is just a diagram from Dr. Hirsch and Dr. Gaspard directly, where we kind of demonstrate the physiology as well as what's going on in terms of brain metabolism and the potential for brain damage as as the patient persists in status epilepticus, even in the context of non-convulsive status epilepticus. So you have ongoing, even if the patient themselves are not demonstrating to you clear manifestations on the outside, if those neurons are continuing to fire in this repetitive phase, then you're going to pass from a pathological standpoint from this compensatory phase into this decompensation phase where there's failure of the homeostasis. You're going to have decreased cardiac output, blood glucose, blood lactate, and blood oxygen, and potentially continued cardiorespiratory collapse, electrolyte imbalances, and potentially even rhabdomyolysis and organ failure. Your brain metabolism, your cerebral blood flow initially is going to compensate, but then is slowly going to decompensate. Same for brain tissue oxygenation and brain glucose. And the bottom line is, as this time goes on, your concern for brain damage overall brain damage continues to increase, especially in the context of convulsive status epilepticus, but also in the context of non-convulsive status epilepticus. Okay, so we continue. Our EEG shows frequent subclinical or electrographic seizures. They're happening at they're lasting about 90 seconds of ictal activity, meaning seizure activity, and they're occurring every 5 minutes. So that puts our seizure burden at about 20%, considered consistent with refractory status epilepticus. Question?
I'm sorry to interrupt. We don't have continuous EEG all the time in our hospital. Sometimes what we do, we put on the bilateral BIS monitor, the bispectral index with the DSA analysis, and looking at the monitor, we may have some insights on what's going on. There are some papers on this. However, I'd like to know your practice. Do you always use EEG? Do you always have it?
Thank you for this excellent question. So I have had the luxury of being an ICU EEG person. I only work in hospitals where ICU EEG is available. So I've always had this luxury. However, this is an excellent idea, is to take a monitor that is easily available and can be seen at the bedside, and to apply it. The thing I don't know about BIS monitors is whether you are able to choose the locations of your electrodes, and I would try, if I were able to choose locations where I expected the seizures to be, coming from, right? So in our case, we had a person who had right facial twitching and perhaps right arm jerking, and so I would prefer having electrodes over the left hemisphere, because if I'm going to use that as a monitor, as a monitoring system, I want to increase, to maximize my opportunity to actually be able to capture. But I agree that the DSA and the waveforms may very well give you some good idea about the physiology. The alternative, I will just say this, is to actually use that monitor to look for essentially artifact coming from subtle sort of EMG, and so you could put it on the ipsilateral side, but I'd be concerned about missing the non-convulsive component. I don't know, any thoughts?
Yeah, very quickly, because we got to move on. But we don't have ICU, we don't continuous EEG available 24/7. But we have electrode caps now that are arriving on the market. They can be easily applied on anyone's head by anyone, even without any prior experience. And I think these will be better than the BIS. The problem with the BIS, with the frontal lead, is that actually you're not covering the whole brain. So if the seizure come from the back, you're going to miss them. So it might be falsely reassuring, but you have the impression that the patient doesn't seize while he's actually still in status epilepticus. I think we have one question there, one question there.
A quick question: do you transport this patient on CT scan without being intubated?
I would not with especially if I'm going to go to my next step, which we'll talk about in just a moment. I would rather fix the seizure first.
in our case, even the routine EEG takes few hours to come by, and same thing, we don't have continuous. So somehow in practice, I don't know whether it's not captured in the guidelines, a few hours that you have this patient who looks like will worry about airway and all that stuff, but somehow we don't seem to care about this non-refractory seizures. Has it not been taught enough? Non-convulsive seizures. We don't seem to care enough. It's 50%. That's the eye-opener, actually.
Well, actually, if you look at the guidelines, whether it's Neuroclinical Society, the American Clinical Neurophysiology Society, they all say that if the patient, within 1 hour of cessation of convulsion, the patient has not regained full consciousness, he needs EEG monitoring. So that's in the guidelines. I agree that in practicality, it might be difficult to set up in many places. Although, again, there are practical solutions that are becoming available nowadays that you should be able to do it. I mean, IT, easy to apply electrode caps, well, you just need a clinical neurophysiologist. But then with AI, even that might become easier in the near future. Okay, I guess we have to move on, right?
I've talked fast, too long. Here's an example of your EEG. Can anybody pick out the seizure quickly? This repetitive activity here in the left, because you see the numbers, the left posterior region is the activity that is reflective of seizure in the left posterior region of this brain. This might be a patient with, for example, PRES or something like that. So how would you manage this patient next? This is getting to your questions, right?
So that's refractory status. What do you do? Intubate and intravenous anesthesia. Everybody would go with intravenous anesthesia at that point. The patient is having non-convulsive seizures. Most of you would go with anesthesia.
Second medication from second line.
Another non-sedating ASM, yeah. So anesthetic or not, that's one of the open questions. If you go for anesthesia, which drug? Propofol, midazolam, both together. Anyone would go with barbiturates, thiopental, pentobarbital? I see a few head nods. No, mostly no. If it's super refractory, you would go with thiopental or pentobarb. Yeah, good point. So maybe not as the first anesthetic line, okay? Oh, an inhalation anesthetics, okay, as a first line. There's not much, no, not as the first line, but as the second anesthetic, if last line. Yeah, okay, so we're getting into super refractory. We'll come there in a moment. Okay, so midazolam or propofol, I like that. What's your target? I mean, this patient has non-convulsive seizures. You don't see anything. You put him on anesthetic drip. Which dose? For how long? How do you monitor treatment in this patient?
Hopefully on continuous EEG.
Hopefully on continuous EEG and
Burst suppression.
Burst suppression. Okay. Any other EEG targets than burst suppression? Is there an advantage of going to burst suppression as opposed to other EEG targets? Someone was saying something over here. No? Okay, you would use the BIS to monitor the depth of sedation. Yeah, why not? That could work, but you would miss some of the seizures maybe. Okay, and how long do you keep the patient under anesthetic drugs? 1 hour, 2 hours, 12 hours, 2 days, a week?
24 hours.
24 hours, yeah, that would be what's recommended in the guidelines. And then what do you do after 24 hours of, let's say, seizure freedom? Do you stop? Do you wean progressively? How long do you take to wean the patient off? It depends on what you use. Would you go faster with midazolam than with propofol, like taper propofol progressively, but stop midazolam abruptly? Yeah, because of the longer half-life of midazolam? Yeah, I do that. Yeah. Right, so these are all the questions, right, that are open questions for which we don't have really a good answer. So what we're going to give you is our take on it. There's a debate about using anesthetic drugs versus another non-sedating second line when it comes to refractory status epilepticus. coming from observational studies that have shown an association between anesthetic drugs and worse outcome. The problem, though, is that there is an allocation bias in those studies. Some patients did receive anesthetic drugs for some reason that maybe the others who did not receive anesthetic drugs didn't have. So it's not really clear if it's the anesthetic drugs itself that kills the patient or the severity of the underlying episode of status epilepticus. So currently, I think most people would agree that you could go with continuous IV anesthetic drugs in convulsive status epilepticus, post-convulsive status epilepticus, and maybe non-convulsive status in patient in coma. People who are already lying in a bed in the ICU, intubated, ventilated because they have a catastrophic brain injury, and you end up finding status epilepticus by doing EEG in those patients. In those patients, probably it's safe to use anesthetic drugs. In other cases of status epilepticus, patient is fully aware or almost fully aware, you don't really want to intubate, because of the risk of intubation, mechanical ventilation, it might be okay to withhold anesthetic drugs and try maybe two other lines of non-sedating anesthetic drugs. Which drug? You answer the question, midazolam or propofol. I think they are relatively equal in terms of efficacy and safety, and certainly they are much safer than using thiopental and pentobarbital. Fewer complications and shorter duration of intubation and ICU stay if you use midazolam or propofol. Which dose? Well, there is no recommended dose, no target dose in my mind. It all goes with which target, and the target is to make the patient seizure-free, right? Control the seizure. It's called seizure suppression. It's one of the EEG targets I was talking about. You probably don't need to go to burst suppression in every patient. First of all, you need propofol barbiturates to reach seizure suppression. Never gonna get, burst suppression. You're never gonna get burst suppression with midazolam. And there is no clear advantage of burst suppression. There's probably a hint of data in the literature suggesting that patients who are in burst suppression do worse than those for which you aim for seizure suppression. How long? The literature, the guideline says 24 hours. I think if you have EEG monitoring, you can go with the EEG. Patient has been seizure-free for 12 hours. There is no angry-looking periodic epileptiform discharges on the EEG. Then you may try to wean and keep watching the EEG. If the seizures come back when you wean, well, you restart the anesthetic drug, and that's it. I usually wean over 12 hours, progressively reducing the dose. I sometimes stop the midazolam abruptly because it has such a long half-life, especially if the patient has received lots of it for several days. With propofol, I like to decrease the dose progressively.
And if you're decreasing the dose progressively, you can continue to monitor the EEG and look
exactly.
for...
EEG monitoring for at least 24 hours of seizure freedom, because these patients might come back in status epilepticus after you've weaned all the anesthetics. This is I mentioned that earlier. Many professional societies do recommend EEG monitoring for the management of refractory status epilepticus. And this is a great quote that I love from Tom Black. The same way you cannot manage a complex cardiac arrhythmia in the ICU without EKG monitoring, you cannot manage refractory status epilepticus without EEG monitoring. Refractory status epilepticus is probably one of the most complicated brain arrhythmia that you might think of. You need EEG monitoring.
A question.
Yeah.
You start to wean the patient, and the patient starts with G-plates, something that's not clearly a status, but is some kind of epileptiform. What do? You sleep you go again with the sedation. We try to wake up the patient.
Now that's an excellent point. What you're referring to, the periodic discharges that arise during the weaning process. The key question is, do these periodic discharges look anything like the ictal activity you had before when you started the anesthetic treatment? If it's the case, then I would consider this as recurrence of status epilepticus. If it's not the case and they look different, you're probably facing what's called GRAWS, generalized periodic discharges related to anesthesia withdrawal, GRAWS. And these are just a sign of a sick brain coming off anesthesia, but not a sign of status recurring. You have to watch them, sit on them, and just wait for them to go away. It can take a couple days. It's very uncomfortable because you have this angry-looking EEG. You desperately want to do something, but you have to refrain from doing anything. They will go away if they don't look like the ictal pattern that you had before treatment.
They are very often, I don't know, I see them a lot with the phenobarbital in particular, the phenobarbital withdrawal, as opposed to, say, a midazolam or propofol withdrawal. And I think we're actually going to talk about the other point, which is when you're putting them on anesthetics, you also want to consider, if you're withdrawing the anesthetics, whether you need to be having a second-line agent sort of like, to cover them while their anesthetics are coming off.
Yeah, so that's what we did. We loaded the patient with levetiracetam, kind of planning ahead of time for when we're going to wean. So the patient has one more anti-seizure medication when we wean him off anesthesia, and we're starting on midazolam drip, that which we increased to quite a high dose. So again, dose does not matter. The key is the EEG. So we went up to 3.2 mg per kg per hour, which is very, very
pretty high.
We usually get call from the pharmacist saying, "You're crazy, you're going to kill the patient." I've never killed anyone, I think, with midazolam, and we've went up to higher doses than that. But despite this, the patient still has seizures, which we call breakthrough seizures. Seizures that still coming despite the anesthesia. All of them are radiographic seizures. That's why you need EEG monitoring. And he had one seizure that lasts for 2 minutes every 10 minutes. So he still has a seizure burden of 20%. So he's still actually in status epilepticus.
So this is the definition of super refractory status epilepticus, as we've discussed. Status epilepticus that persists despite your addition of your anesthetic regimen, right?
Oops, sorry.
So what treatment options have been used? And we've discussed some of them already in the context of super refractory status epilepticus. You have a question?
Ketamine I will use.
Why?
Maybe infusion. I just read in last paper, especially in cases of autoimmune encephalitis, if there is any disease. So playing on NMDA receptors in this case may resolve some problem.
Okay, ketamine, I like that. Excellent.
I just realized the time.
Yeah.
We need to be fast. Another question
here. Just to comment, because part of we decided to do a head CT and then EEG. So first of all, I wanted to ask, did we see anything on CT scan? And is there room, a young patient with fever, is there room for LP as well? And to maybe he has some sort of a meningitis, start antibiotics to treat the etiology of the disease.
Excellent. You're anticipating the rest of the presentation.
Yes,
so
thank you.
Maybe quickly over super refractory. Ketamine is an excellent suggestion. We do that quite often. Of course, you can try more anesthetic drugs. Either you start a patient on the one that failed, you switch to another, you combine midazolam, propofol. I heard that. Maybe you go to thiopental, pentobarbital. I always try not to go there because I know that the patient is going to be down for at least 10 days with all the complications associated with that. So I still try to stick to midazolam, propofol, and ketamine. Inhalational anesthetics were suggested. Another good idea. You can try more anti-seizure medication, IV, enteral. You can give immune therapies. You can actually treat maybe the etiology of the treatment. So ketamine, the reason we like ketamine is because it's synergistic with midazolam and propofol. Midazolam and propofol are mostly GABA-A receptor agonist. Ketamine is an MDA receptor antagonist. You actually fight status from both fronts at the same time. You increase GABA neurotransmission, you decrease glutamate and MDA neurotransmission. And we like combining both midazolam plus ketamine. It also has a supportive effect on cardiovascular function. If the patient if its volume is high enough, you actually might decrease the pressors that you had to put the patient on because of the midazolam and the propofol when you use ketamine. So two good reasons to use ketamine. So we'll skip that. The patient was in burst suppression, and from these bursts, which kind of look angry with spikes in them, he still had seizures. So it's super refractory status epilepticus. What else can we do?
And this is what we got to already in terms of the actual workup, right? You want to read your other?
Yeah, another quote from Tom Blake. He had great quotes, Tom Blake.
Yes.
The status epilepticus, if you think about it, if you're a neurologist, it's kind of paradoxical because it's nothing like the way we usually do things in neurology. In neurology, we first like to make a diagnosis and then treat the etiology. In status epilepticus, all the way from early status epilepticus to super refractory status epilepticus, we think about one thing: stopping the seizures with symptomatic treatment. But at some point, we've got to think about etiology as well.
So you mentioned a couple of underlying etiologies, which are the ones for sort of new onset refractory status epilepticus. Already we should have been thinking about the more frequent and obvious etiologies, right? So known prior history of epilepsy, and maybe they've stopped their medications or lost access to their medications. Certainly any sort of acute brain injury, TBI, stroke, hemorrhage, etc. Looking for meningitis, for typical CNS infections, and then any electrolyte abnormalities, hypoglycemia, hyperglycemia, hyponatremia, etc., and certainly drug toxicities. Then our less frequent or less obvious things, our autoimmunes, our paraneoplastic issues, and so getting this LP to rule out some of these other things, but also going deeper if need be and repeating for paraneoplastic panels and such may be in order. And then particularly in your young children, looking at the possibility of genetic disorders playing a role is very, very important. 10% are cryptogenic. Let's see. New onset refractory status epilepticus. I think that you guys may be familiar with this concept. These, in terms of the causes that have been identified, 70% cryptogenic. Despite all of your efforts, you find nothing, right? And that's partly because there may be nothing to find, and partly because our advances have not yet gotten to the point of being able to identify all of the antibodies or what have you that may be involved. But other things that you can potentially find, autoimmune encephalitis due to cancer, or just because there's an autoimmune predisposition, as we discussed, genetics, and then uncommon infections. Remember your uncommon infections, particularly in folks who have a travel history to places that are endemic for certain things that may be outside your typical regions. Other things that they can experience because of their own immunosuppression that they may or may not otherwise experience, etc. We can go forward. Oh yes, so. The FIRES is the other term, particularly for those of you who work in pediatrics, febrile infection-related epilepsy syndrome, which is a subcategory of new onset refractory status epilepticus. They often start with a sort of a minor presumed viral illness, leading to what we think is a rev up of innate immunity with cytokines and macrophages, which cause this hyperexcitability of the neurons that can lead to status epilepticus, and unfortunately generate sort of a self-propelling cycle, if you will. Do you want to talk about the recommendation?
Yeah, right. And this patient is NORS, right? New onset refractory status epilepticus. It's a very complicated situation to manage because aside from the treatment part, there is all these what's the etiology question that come to mind. And we realized a few years ago that there was really no strategy that was proposed to approach these patients. So Ronnie Wickstrom was the lead author on these Delphi-based recommendation on how to approach a patient with new onset refractory status epilepticus in terms of management and etiology. I won't go into the detail. You can look up the paper. There is a short version, a long version. The short version is really fine. The long version explains how we did all the Delphi process, but it's really not really relevant. This is one of the tables in the paper. Again, go look up the paper online. I'm not going to read all of those, but it's kind of proposing a way to a tiered approach to management in terms of treatment and etiology finding in those patients. The reason it's important to recognize those patients with cryptogenic new onset refractory status epilepticus is that they might not respond to any anti-seizure medication, any anesthetic drug, and respond spectacularly, dramatically to immune therapies. The ketogenic diet has been tried in children. ketogenic diet has anti-inflammatory properties. And drugs that target the interleukin-1 beta, interleukin-6 pathway, anakinra, and tocilizumab. I'm sure you're all familiar with tocilizumab from the COVID pandemic. It actually works in those patients because we believe that the status episode in those patients is caused by elevations of cytokines that have a pro-convulsant activity. So there are case series out there. In my experience, they work usually very, very nicely. They have side effects, of course, that you know. So let's wrap it up because we're a bit late. Apologies for that. At least you're going to skip the line for lunch. Everybody's lining for the lunch. You will arrive after the line's over. So the patient was started on steroids, which did not help at all. He received a total of 10 different anti-seizure medication and anesthetic drugs to maximally tolerated dose. Finally, we started him on tocilizumab, and the seizures abated after 27 days in total. Within 48 hours of tocilizumab, he was seizure-free. But it took us 27 days to get there, to get him seizure-free. Developed all the complications you can think about for a patient with prolonged intubation and sedation in the ICU, infection, shock, anemia, pulmonary embolism, drug allergy, neuromyopathy, and so on. Spent 95 days in the hospital, including 45 in the ICU. That's quite a long time. Was discharged from rehab facility, and I saw him a few months ago. He's doing great. He's cognitively back to normal. He still has drug-resistant epilepsy, but he's back to college, despite 27 days of super refractory status epilepticus and 95 days in the hospital. So the message here in that, and we didn't show any image because MRIs and CT scans were all normal in this patient, all normal. So in these young folks with super refractory status epilepticus with no clear etiology and normal brain imaging, never give up. They can have an excellent, excellent outcome despite what looks like intractable status epilepticus.
Thanks. A quick question. I work in pediatric practice, so Norris and fires is something that's not infrequent. Often when you get to the point of going to the ketogenic diet, you've been on high-dose steroids, so it's very difficult to get ketosis. Over-the-counter ketones are available in sports nutrition now. They're using them in triathlons and cycling. Has there been anyone trying to using them to induce ketosis with those? They're just commercial products.
We just use the ketone diet that's available in our hospital. I've never tried over-the-counter versions of it.
Yeah, I think it would be worth a trial. I'm not sure. I think though it's the state of ketosis in terms of the glucose, the glucose deprivation state that at least that's my understanding, that has this benefit. So I'm not sure that adding the ketones would have the same benefit, but I don't know this for sure. And I think that it would certainly be worth trying out in a rigorous, systematic way.
From animal models,
if you're giving paraldehyde, you said? Giving paraldehyde has the same physiology.
Well, paraldehyde has been tried. I mean, it's one of these drugs that you can try at some point. It just somehow works like ketone buddies. And if you believe the animal literature, yes, you would think that giving hydroxybutyrate, for instance, could have a direct anti-seizure effect. It's not the only thing that the ketone diet does, though. So, like Shawniqua was saying, I'm not sure it would be exactly the same, but it's worth a try. It's definitely worth a try.
Yeah, from the perspective, as you said just at the end, that these are kids that have a potential for success. So try everything that you can. We don't have very good answers.
Yeah, and back to your question about steroids and not being able to achieve ketosis because of steroids. I think nowadays in a FIRES kid, I would skip steroids and go to ketogenic diet first because steroids usually don't work in those patients.
Thank you.
All right, thank you very much for showing up and staying with us that late. Have a good lunch and enjoy the end of your meeting.